and probably these people should be closed. And third is just an atrial septal aneurysm only without a PFO is not a risk factor for stroke. So these are the most just simple conclusions that I can make. So what are the options that you can do to prevent strokes in patients with PFO? Currently there are no established principles. There's no established guidelines. And the options available are antiplatelet therapy, anticoagulation, surgical closure, or percutaneous closure. And these are probably the most common ones which are widely used, anticoagulation versus percutaneous closure. Is there any randomized studies complete? Actually, there is one randomized study, but there's no data available from any randomized studies. But what we do have is retrospective analysis of non-randomized studies. And if you can put all these patients together, these are just transcatheter closure studies, and these are set medical management studies, about 1,000 patients either side. Important, these are not randomized studies. You can see the recurrent neurological event at 1 year is 0 to 4.9% if you had closure with aspirin, versus just controlled medically is 3.8 to 12%. And in this category, most of them are like TIAs. This is enough evidence to tell you, retrospectively, that probably closing a PFO with medical therapy is probably superior to just medical therapy alone. The caveat and the problem of this data is that these were not randomized studies. These were just controls versus retrospective analyses. And that's why they are true, not apples versus oranges. Now, what about migraines and PFO? There's an association. And how this association came about was we closed patients with PFOs with strokes, and they came back thanking us. And I said, why are you thanking me? We just did it to prevent a stroke. And then, Dr. Carr, actually my migraines have gone away. I said, what? We never even closed it for your migraines. That is the way we actually found about this clue. And this actually led to retrospective analysis which demonstrated that actually closures of PFO reduces migraines. And there's an association clearly with migraines and PFO. There's also a known association of migraines and strokes. And therefore, and the third conclusion found where the PFO closure for stroke patients with headaches actually reduced the headaches. So all of these put together tells us there's maybe a relationship between certain types of migraines and PFOs. And you say, how the hell can there be an association? And probably, if you have a PFO, you can have a small shower emboli which can lead to strokes and white matter lesions. You can have a PFO and you get shunting hypoxic blood with unidentified neuropeptides which go bypass the lungs and go straight into circulation and cause migraines and these stroke and white matter lesions. So here's an association. Unfortunately, there's no clear-cut data for this. There was the MIST trial which randomized patients with severe migraines with PFOs to closure versus placebo, and they found that the device closure showed a 42% reduction, but the control arm also showed a 23% reduction, which tells us there may be a placebo effect in the study. So we were not clear-cut with this data, but it suggests that maybe it may benefit. And then finally comes scuba divers and PFO, and it is a retrospective analysis of scuba divers with PFO. And here you can show you that if you have a PFO, and those who don't have PFO, this is a very important thing, you will notice that the incidence of decompression illness is higher with patients who do have PFO compared to scuba divers who don't. And this has led to a lot of people, especially in the Army and the Navy, if they do have a PFO, they don't allow them to continue to dive till they have their PFOs closed. There's no, again, it's very difficult to do a randomized study on this group of patients because they're normal people, but this is quite suggestive that if you do have a history of decompression illness and you have a PFO, and especially if you're a diver, you need to have it closed. So putting all of this perspective together, what are the indications of closure? Primary prevention, no role. Patient with recurrent cryptogenic strokes despite medical treatment, absolute indication for closure, no doubt. What about people who have their first stroke and have an event and have a high-risk PFO, especially a large PFO with a septal aneurysm? What do you do with these people? These people, in most clinical scenarios, I think should be closed. In the United States, because there's no FDA-approved device, we have to put them in trials. But probably, I think realistically, patients come to you and tell me, look, why should I wait for a second event? If you think it's related, close it. If you don't think it's related, don't put me in the trial. So it's very difficult So I think these are the group of people who should be closed if you don't have a trial in that country. But in the US, if you have a trial, if you have a single event and a PFO, you should encourage them to participate in a study. Scuba divers. Scuba divers with a history of decompression as a PFO, it should definitely be closed. Orthodeoxyplatypnea, which is a condition where you are in a position you get PFO, this is probably not. Intractable migraines and histories of TIAs. If you have intractable migraines and you have TIAs, probably this is another indication of closure. Again, finally, if you have a migraine and a PFO, and if your center has a trial, please try to put them in a trial. Techniques of closure. This is not true for India, but it's true for the US. No FDA-approved PFO device available for commercial usage. Nothing. All that is available is devices in clinical trials are off-label devices. And if you show you, they're actually the same devices. So here is the StarFlex device, which is one of the original devices ever used. And then it has its new counterpart, sorry, which is actually not showing up on the slide, but which is basically the BioStar, which I'm not showing up here. The BioStar is a material where the device actually, this is not cloth, but is made of collagen, and you just have a metal framework. So what happens is the device stays in the body, the collagen completely gets absorbed, and you're left with nothing and just left these three metal frames. You have the Amplatzer PFO device, a cribriform device, and you have the Helix septal occluder. The methods of closure. Now, in the US, we tend to use a lot of intracardiac echo. I know in India you use TE because of the cost, but we think intracardiac echo just through the groin without anesthesia with local is quite effective. You go through the right groin, you find the PFO through just with a multi-purpose catheter and a wire, you go across it, and then you use a device which is about 2 times the size of the tunnel of a PFO, and basically you deploy the first umbrella, you pull it back. It's very similar to what you close for septal occluders. You deploy the second umbrella, and then you deploy it, and then it gets covered with tissue. Most patients have to be on aspirin forever, Plavix for 3 to 6 months. Success rate is greater than 90%, 10% residuals, recurrent events less to 0 to 5%, erosions less than 1%, thrombus between different devices about 1 to 2%, vascular complications about 1 to 2%. So it's not a very dangerous procedure. Any trials available? These are the 3 trials that are in the US now: RESPECT, Closure 1, and REDUCE. Different devices. The Amplatzer device is the RESPECT trial, the StarFlex is the Closure 1, and the REDUCE is the Helix device. There's only one study that has completed, is the Closure 1 trial, which I'm one of the actually executive members, and we will have this data out within this year. For the first time, we're going to have a randomized data probably by September, October. So we will see what happens in this group of people, whether they benefited from closure or they're inferior. Challenges of enrollment. Why did it take so long to enroll these studies? Slow enrollment because patients did not want to get enrolled. Nobody wants to be randomized if they have a stroke. Closure devices with older generation, you always had that bias between neurologists and cardiologists. Cardiologists want to close everything, neurologists don't want to just treat them medically. There's a patient bias, and the low-risk patients therefore got enrolled in the study. So what's going to happen now? These patients, we couldn't enroll the patients within the study, only a few got enrolled, and this is the problem. Most likely the trials are going to be negative. But what if it's negative? And however it's negative, the cardiologists won't believe it. If it's positive, the neurologists won't believe it. So we're left in a no-win situation. Therefore, just use your clinical judgment and use common sense and dictate it. So if you have a young person who's had a PFO and a stroke and there's no other obvious cause, it's reasonable to consider closure with medical treatment. It's not closure against medical, it's closure with medical treatment. So in conclusion, we can say over here that there's a clear-cut and a definite association of stroke, decompression illness, and possibly migraine in patients who have PFOs. Percutaneous PFO closure is indicated in patients with recurrent strokes, or even the first stroke, I think, and decompression illnesses. Several devices are available for percutaneous closure for PFO outside the US, but in the US you have off-label devices that you can use for closure. And patients should be encouraged to participate in trials if there are trials available for you. But whenever I tell people of closure, there's always a fear. We always make it very easy. This is nothing. But I always tell people, be careful. Whenever you're doing a procedure on a patient, You always have to weigh the benefits, potential benefits, versus the risk of the procedure, even though they're small. And that's why I want to end with the interventionist cardiologist's brain. This is what an interventional cardiologist's brain looks like. This is Milanchuk's brain, by the way. These are his physical needs, main frontal lobe. Then over here, you can see over here, this is basically his motor skills. And then finally, this is a very large developed area of the brain. We have this oculostenotic reflex, okay? We see a narrowing, we want to open it. We see a hole, we want to close it, right? This is just a reflex. And the problem is that this is a small part of the brain which is very underdeveloped in interventional cardiologists. And if you look at what that site is, it's the memory storage for complications. Thank you very much.